welcome to Beat Diabetes, Myths and Facts. I'm Ankita Mukherjee. This is where we bring medical experts in to talk about how we can cope better with chronic lifestyle diseases. While dealing with COVID-19, we overlooked the fact that people's lifestyles were getting severely disrupted. Many people have become physically inactive. Some have developed irregular eating patterns. That in turn has led to unhealthier lifestyles and aggravation of lifestyle diseases. Now, COVID-19 has also caused significant changes to our homes, to our work lives, to our stress levels. And we're taking a closer look at how healthier diets and increasing physical activity can help slow down what is turning into a veritable epidemic of diabetes and heart diseases. As always, experts joining us on the show to help us live better lives. Dr. Amit Rastogi, MD, DM Endo, Senior Consultant Endocrinologist with the RK Endocrine and Eye Clinic in Meerut is with us. Dr. Satyam Chakraborty, MBBS MD, General Medicine, DM Endocrinology and Metabolism. Endocrinologist with the Fortis Hospital in Kolkata is on the show today, as is Dr. Arvind Yuvraj Narasimhan, MD, DM, Consultant Interventional Cardiologist with the Naruvi Hospital in Vellore. Dr. Amit Rastogi, let me begin with you. We've seen people developing health complications after recovering from COVID-19. So are people with diabetes actually at a higher risk of developing health complications even after they recover fully from COVID-19?
Yeah, that's a very important clinical scenario which we are observing post-COVID recovery. And this is what we call it as a long COVID syndrome or a post-COVID syndrome. Patients are complaining with myriads of symptoms and signs like extreme fatigability, insomnia, cognitive dysfunction, palpitation, difficulty in breathing, hair fall. So all these symptoms are coming up even after 12 weeks once the patient have recovered from COVID-19 infection. We saw in the first and second wave that there were various comorbidities which led to the severity of COVID-19 infection as well as mortality, and diabetes was one of them. So what are the reasons why these individuals are having this post-COVID syndrome? And one of them is uncontrolled diabetes. Other aspects are female gender, obesity, and those who have a poor glycemic control. Patients who have been given steroids for a long time are more prone for this complication. And the only way, as of now, we can handle this particular situation is having a strict diabetes control. Not only that, other comorbid conditions related with diabetes like hypertension, dyslipidemia needs to be taken into account. Patients needs to be given psychological counseling. Rehabilitation program has to be assessed so that their diet and their exercise and their stress levels also get improved.
Right. Dr. Chakraborty, are post-COVID-19 complications different actually for people who have type 1 and type 2 diabetes? Have you seen differences in your patients with diabetes?
We have to understand few things, that it is basically the hyperglycemic milieu which dictates how complicated a COVID patient will be when the patient gets COVID infected. So if the patient, whosoever he or she may be, whether he or she may be a type 1 or a type 2 diabetic patient, if the blood sugars are well under control, the chances of developing severe post-COVID complications are minimal or negative. Maybe there may not be any post-COVID complications. But if the blood sugars in a COVID patients are not controlled and they have a bad glycemic history, the chances of developing severe COVID infections and also post-COVID complications like pulmonary complications, the cardiac complications, they increase. So it is basically the hyperglycemic milieu which dictates the complications in a COVID patient.
That's, of course, as far as diabetes is concerned, but otherwise healthy people who are recovering from COVID-19 are also sometimes seen to be suffering from a cardiac arrest. Now, is that just because of stress, or is this actually a side effect of COVID-19? Dr. Arvind Yuvraj Narasimhan, if you would like to answer that.
We wouldn't fully agree that it can be just due to stress as such. At least it is very unlikely that it is due to the psychological stress alone that a patient goes into a fatal cardiac arrest. One thing that is very well established now is that the COVID infection does cause a mess out of our immune system, which results in an accelerated or exaggerated inflammatory response, which in a significant percent of cases cause a coagulation disorder. This coagulation disorder, when happens in a person with COVID infection, makes them susceptible to develop blood clots in their blood vessels. These blood clots, when they go migrate and clog any of the vital blood vessels, say for example the pulmonary arteries or the coronary arteries, it causes an abrupt stop in the blood supply to the lungs and heart respectively. So answering to your question, if the cardiac arrest in a COVID patient is as a side effect of the infection, I would say yes, it is.
All right. Dr. Rastogi, diabetes mellitus, of course, is a group of metabolic disorders that's characterized by elevated blood sugar levels. But is there an association between diabetes and endocrine disorder, related to the pancreas? What are the connections over there, if you could explain to us?
Yeah, see, diabetes is a chronic metabolic disorder, and which is diagnosed when the blood sugar levels are exceeding the upper limit of normal. It not only affects the carbohydrate metabolism, but also affects your protein and lipids. The age-old teaching is that either it is because of improper secretion of insulin hormone from the pancreas, or the insulin hormone is not acting as it should. The state we call as insulin resistance.
Right.
Now, there are other hormones in the body. For example, I state two examples of growth hormone and cortisol. These are just the steroids which are given from outside for so many reasons, and we saw in COVID-19 infection too. So whenever there is an excess of growth hormone, for example, an endocrinopathy like acromegaly, the pituitary gland secrete a lot of growth hormone. So they nullifies the effect of insulin, and therefore the blood sugar rises. Another example is the endogenous production of cortisol level. Again, it causes a state of insulin resistance. So the defect is not primarily at the pancreas. They are endocrinopathies, the endocrine organs, which are over-secreting hormones, which attenuates the effect of insulin. Once you take care of these endocrinopathies, most of the individual sugar levels can come back to normal or will be easily controlled by other agents like insulin or oral hypoglycemic agents. So one of the important insight into the pathogenesis of diabetes, especially type 2 diabetes, which is the commonest variety of diabetes, is that our kidney are reabsorbing a lot of glucose more than what is expected, and this leads to increase in the sugar levels. It is independent of insulin levels in the body. And once by means of oral medicines, we are able to block these channels, the glucose get excreted in the urine. And this is what we have exploited in the clinical practice. We are using these medicines a lot, and they are improving the diabetes status in a lot of our patients. So once all said done, the clinicians need to be very alert that all diabetes is not because of type 2 diabetes, which is the commonest one.
Right.
There are other reasons, example endocrinopathy, which has to be taken care of.
Dr. Chakraborty, diabetes mellitus may occur in association with endocrine disorders. So what are the other endocrine disorders that you do associate with diabetes? And, is there anything that actually causes secondary diabetes as well?
So the most common associations what we find in our day-to-day practice in diabetic patients is thyroid disorders, hypothyroidism most commonly. Others may be adrenal disorders, which are quite rare, but in long-standing diabetic cases, you might land up with a patient who has diabetes and adrenal insufficiency because of adrenal tuberculosis. In a rare instance, you will also find Cushing's syndrome, which I will take in the second part of the question. Basically, secondary diabetes. You have to understand insulin is an anabolic hormone and which modulates the blood glucose levels. The other hormones which are being secreted in the body, like the growth hormone, thyroid hormone, adrenal hormones, these are all catabolic hormones and they increase the blood glucose level. So at any point of time, if there is a tumor which secretes excess of these hormones, there will always be an uncontrolled blood glucose levels. For example, acromegaly, that is a growth hormone secreting tumor, a TSH-OMA, that is a TSH secreting tumor from the pituitary, The third may be a Cushing syndrome, where there is an adrenal tumor which secretes excess of adrenal hormones. A pheochromocytoma. In cases of pheochromocytoma, sometimes you may have hyperglycemia. So these are the areas, and sometimes patients who are on indigenous system of medicines which contain steroids which are not known, then if the patients with they consume this type of medications, they will develop Cushingoid features and they will have uncontrolled hyperglycemia also.
All right, that was a very detailed and comprehensive answer, Dr. Chakraborty. We will take a very quick break at this point. When we come back, a closer look at hypertension, the connection between smoking and hypertension, and much, much more. We'll be back in just a moment. Welcome back to Beat Diabetes, Myths and Facts. Dr. Narasimhan, let me get into it straight away. Do people who have hypertension need to take blood pressure medications for the rest of their lives? Can they actually stop medications at all once their blood pressure is normal?
The answer for this in most cases will be depending on what is the reason for the hypertension that the patient has. Broadly, we classify hypertension as primary and secondary hypertension. Almost 90 to 95% of patients having hypertension come under this first type, that is the primary hypertension, which can be also called essential hypertension. Basically, the primary or essential hypertension means there is no exact cause that we can identify behind the person's hypertension, but only we are able to identify the risk factors like smoking, excessive alcohol consumption, obesity, age, a family history of hypertension that are strongly and independently associated with the development of hypertension. Patients with some of these risk factors that are not modifiable, like age, a family history of hypertension, will in most cases require medications for lifetime. But in patients with other modifiable risk factors like smoking, excess alcohol consumption, obesity, etc., a strict diet and lifestyle modification, smoking cessation, refraining from alcohol consumption, and weight reduction, they all significantly help bring down the dose of the hypertension medicines. And in some patients, we are even able to stop their hypertension medicines completely if they adhere to the strict diet and lifestyle modifications.
Dr. Amit Rastogi, is it true that women with diabetes often have more serious complications and perhaps are at greater risk of death?
Yeah, gender association with diabetes is well known, and especially in terms of macrovascular complication like coronary artery disease and heart failure. The commonest cause of mortality in type 2 diabetes is heart disease. So in women's, it has been found out in the age group of 40 to 60 years of age, there is about 4 times more chance of coronary artery disease as compared to men, which is only just 2 times the men without diabetes. Not only this, it has been found out the pumping of the heart goes out of order, what we call as heart failure. And it's a very important clinical scenario which need to be understood nowadays, that it is 6 times more common in women as compared to men. Why this is so? It may be because of the hormonal changes or the hormonal status in women. It may be because of multiple risk factors which are there in them more. And after a certain age, when the lady lands into the postmenopausal stage, the protection of the various hormones like estrogen goes away, and diabetes attenuates the effect of these hormones. And there may be some extensive atherosclerosis, that is deposition of the lipids in the arteries. And last but not the least, it may be that is suboptimal evidence-based medicine not being offered to women. The women health is often neglected. So that's why these complication in diabetes might be more in women, leading to more mortality than in men. Other comorbid conditions which are more in women in diabetes is thyroid disorder, which is another commonest endocrine disorder which we see. It may be related to an autoimmune disorder, and therefore we can keep a close eye about thyroid status in women.
Stopping smoking, of course, is one of the most important actions that people who smoke can take to reduce their risk of cardiovascular disease. But does this actually reduce the risk of a heart attack immediately, or, what are the long-term effects of quitting smoking? Dr. Narasimhan?
As we all know, smoking is one of the vital risk factors which independently adds to a person's risk of getting a heart attack or a stroke. As a matter of fact, smoking is found to be directly related to almost 1 out of 4 heart attacks that we see in daily practice. Smokers, when compared to non-smokers, are at almost 3 to 4 times higher risk of developing a heart attack or a stroke. A person has to be sober for at least 10 years after he or she quits smoking for the risks of developing a cardiovascular problem to come down to the same risk of a non-smoker. So if you ask me, does quitting smoking reduce the risk of a heart attack immediately? The answer is no. If we only quit now, today, our cardiovascular risks are equal to that of a non-smoker only after 10 years. Speaking of long-term effects of quitting, it's all only positive effects. Your heart attack risk goes down, the stroke risk, the cancer risk, the risk of developing COPD, they all go down with just quitting smoking. That is the long-term effect. What more do we want? So there are countless number of reasons why we should stop smoking right away, and not a single reason to only stick on to it.
All right. Dr. Chakraborty, a quick last question to you. Do people with diabetes need to do checkups for other endocrine disorders, and what tests should they be taking? And if you could give us a sense of how frequently these tests should be taken.
The most commonly associated is hypothyroidism. That's why a thyroid function test in diabetic patients is mandatory at the first visit, and then every 2 to 3 years. The second one, which needs a special mention, is a bone disorders in diabetes. Particularly when the patient goes into diabetic kidney disease, the bone morphology should be tested, the bone density should be tested, particularly again in postmenopausal females who are long-standing diabetic patients. The bones tend to become fragile, friable, and fracture without any significant trauma. That's why the bone assessment is mandatory. In long-standing cases of diabetes, it is the clinical scenario which dictates whether we should go for other endocrine evaluation or not. Maybe at times when the patient's sugars suddenly come down, there are recurrent hypoglycemias in the patient is not eating well, the chances of adrenal insufficiency increase, and that's why we have to check for the adrenal hormones and we have to treat accordingly.
All right. Thanks very much indeed, doctors, for joining us on the program. That's all we have time for on this edition of Beat Diabetes Myths and Facts. Thanks for watching.